Okay, good morning. Let's get started. Welcome to Hope Hospice's Family Caregiver Education Series. I'm Debbie Emerson, Hope's Community Health Educator and Certified Dementia Specialist. I've been facilitating the Family Caregiver Program for nearly 9 years now. And in addition to my many years of experience as a health educator, I also have a lot of experience as a family caregiver. So my goal today, as always, is to share information with you that's based both on my professional training and my personal experiences. Now, in the past, I've mostly relied on my experience with aging parents and in-laws, but I recently had an unexpected emergency stay in the hospital. It was not a good experience, but it very definitely validated my passion about the importance of self-advocacy. All right, so here's today's agenda. I'll start with the importance of using effective communication skills, followed by tips for organizing and managing personal health information. I'll cover hospitalizations and the rights and responsibilities of care partners. The discharge process and planning for follow-up care can be stressful because there are so many decisions that need to be made. So I'm going to try to give you some guidance to help you better manage this while keeping your sanity and protecting your rights. Now, by the way, I'm assuming that most of you are caring for someone who is on Medicare or you're on Medicare yourself. And while I'm going to address some other insurance plans, much of the presentation focuses on your rights under Medicare. So the word advocate, when used as a noun, is a person who speaks or writes in defense of another person or a cause. So an advocate is someone who has your back, so to speak. They're there to help you at times when you may not be able to help yourself. As care partners, being an advocate for our loved one is one of our most important jobs. And the key to being an effective advocate is to use good communication skills. Now, there are 4 basic communication styles. I am sure that you have heard all about these, but I always think it's a good idea to refresh our memories. Because if you're like me, under stressful situations, I tend to revert to the less effective styles. Passive communicators are those who have difficulty expressing their wishes, their needs, or their opinions. They don't stand up for their rights, and they tend to allow others to run the show, walk all over them. Sometimes they find it easier just to keep their mouths shut and let others have their way. But this is not good, because when we're passive, we lose our self-respect. And when we don't respect ourselves, it's hard for others to respect us. We can show our passivity not only by the words we use, but by our tone of voice and our body language. We project that we're weak, and then it's harder for us to get what we want. The flip side of this is an aggressive communicator. These individuals express their feelings and opinions and advocate for their needs in a way that violates the rights of others. Thus, aggressive communicators are verbally and/or physically abusive. These are the bullies, the ones who try to get their own way by pushing others around. They don't really care about you or your needs. They just want what they want. And they can be mean and disrespectful, maybe using humiliation to control others. And not only are their words aggressive, but their tone of voice and their body language also project this. They can be in your face, speaking loudly and demanding what they want. Aggressive communicators are not good listeners. They don't feel like they need to be because others don't matter. It's all about them. Passive-aggressive communication is the style in which individuals appear cooperative and agreeable on the surface, but they may purposefully try to anger or disrupt. They purposely become angry or disruptive. They may feel capable of dealing directly with people with whom they disagree or feel intimidated by. But instead, they express their anger in sneaky, behind-your-back ways. So if I'm behaving passive-aggressively, I may act like everything is fine and all sweet and submissive, but I'm going to write the nastiest Yelp review ever, or try to sabotage you in some other way to get even. My facial expressions may not match how I really feel. I may be smiling, but inside, I'm really ticked off. So I never learn how to communicate in a way that respects myself or respects others. Now, assertive communicators clearly state their opinions and feelings and firmly advocate for their rights and their needs, but without violating the rights of others. And this is the big difference between assertive and aggressive. Assertive individuals value themselves, their time, and their own needs. They are strong advocates for themselves while being very respectful of the rights of others. They listen well without interrupting, they make good eye contact, and they have a relaxed posture. They speak clearly and honestly. Everything about them shows that not only do they respect you and value what you have to say, but that they respect themselves. So, of course, being assertive is the best option, right? Being assertive allows us to take care of ourselves and is fundamental for good mental health and healthy relationships. So, I don't know about you, but there are times when I have used all of the ineffective communication styles. Even though I know that being assertive is the best, there are times in my life when I'm passive. I can be aggressive, and I've also been passive aggressive. I found that the style of communication I use is affected by the situation. In circumstances where I feel confident, it's pretty easy for me to be assertive. But if I'm feeling insecure, my passive side comes out. When emotions are high and I'm feeling stressed, that's when I can lean towards being aggressive. I'm not proud of this. When I was caring for my mom and felt like her needs were not being met and I was stressed out, well, that's when Mama Bear surfaced. I had to remind myself that to be a good advocate for her and myself, I needed to breathe and tell myself that being angry and aggressive was actually doing us both more harm than good. Our general temperament can influence our communication styles. Now, some of us are type A personalities, quick to rile, overly active, high strung. Others are, by nature, more easygoing and mellow. Now, if we've established a particular communication style in the past and feel as if it has worked for us, maybe even if it didn't really respect others, we may default to that style. And although it may have worked for us in the past, once we become advocates for our loved ones, really the best way to go is to try to be assertive. So are we stuck? Are we doomed by our past patterns? I don't think so. Try to identify the triggers that can cause you to be aggressive or passive. If you know, for example, that strong authority figures can make you feel inferior, just remind yourself that you and your needs are just as important and you deserve to be respected and heard. And practice, maybe in your head. Or if you've just been in a situation where you didn't communicate as effectively as you wished you had, replay the situation and try to come up with a better reaction or response. We can learn to be better communicators. Remember, being assertive means we can clearly state our opinions and feelings and firmly advocate for our own rights and needs without violating the rights of others. Now, how well you communicate with healthcare professionals is one of the most important parts of getting good healthcare. But sometimes that's not always easy. In the past, the doctor typically took the lead and the patient followed. But today, a good patient-doctor relationship is more of a partnership. And you, as the family caregiver and advocate for your loved one, are an essential part of that partnership. Actually, it's more of a team that also includes nurses, physician assistants, and other healthcare professionals. Good teamwork is necessary to manage medical problems and to keep your loved one healthy. So establishing a partnership can begin with assertive, respectful communication. Let the physician know that you are there not only to help your loved one with their needs, but you're there to help the physician. Now, the physician, of course, is the medical expert, but you are the expert with regard to your loved one's history. You know their abilities, and you also know what they need. And you know the best way to communicate with your loved one. So remember, with assertive communication skills, we treat others with the respect they deserve, but our demeanor, our good listening skills, our patience, and sincere interest show the healthcare professional that we too are worthy of respect. The family caregiver's role is just as important as anyone else on the team. Now, healthcare professionals can't do their jobs unless we're honest. This is especially true if you're reporting on signs of cognitive decline or dementia. By the way, you may want to talk with your loved one's doctor about issues regarding dementia at a private appointment, consultation, phone call. This is an area where complete honesty is essential, and you need to be able to describe signs and symptoms without fear of upsetting your loved one. If the physician says that he or she cannot discuss your loved one's case with you because of HIPAA, well, that's not entirely accurate. And we're going to talk more about that later. So this brings up another potentially sensitive area for caregivers. Most medical professionals prefer to talk directly to their patients. This is important for a couple of reasons. One, doctors rely heavily on their powers of observation, and they want to hear directly from their patients. They want to see how the patient reacts and responds. And they assume that the best person to report on healthcare matters is the person themselves. And two, speaking directly to the patient is a sign of respect. Some patients can get petulant and angry if their spouse or adult child is talking for them. It can be humiliating to an adult if others assume that they no longer can speak for themselves. So we as caregivers need to be especially sensitive to that. I remember the first couple of times I took my mom to the emergency room or to a new doctor, the doctor would ask direct questions of my mom. Now, this was hard because her answers tended to be inaccurate because she had dementia. But having been an ER nurse herself her entire adult life, she was highly believable because she could still talk the talk. But her inaccuracies would not result in her getting the care that she needed. So I would try to slyly get the attention of the doctor and kind of shake my head, but it was hard. I didn't want to totally contradict my mom and risk embarrassing her, but neither did I want the doctor to get the wrong information. So I found a solution that actually worked in our case. Since my mom had a rather complicated medical history, and every time she had a hospitalization or went to a new doctor, we had a ton of information to share. So I began putting all of the pertinent info on a sheet of paper. I called it her brief medical history. And this included her contact and insurance info, her diagnoses, the list of specialists that she had seen, a list of hospitalizations and treatments, and an up-to-date list of medications. By the way, I'm going to show you all this on the next slide. So I kept this info on my computer, and I updated it after each appointment or hospitalization. And I always kept a hard copy of this in my car because we never knew when an emergency would arise. Now, I showed this document to my mom, and I told her, you know, Mom, every time we have to go to a doctor or a hospital, they always ask us the same questions over and over. And I know we both have a hard time remembering everything. So from now on, when they start with the questions, I'm just going to hand them all the answers. I'm sure they're still going to, I'm sure that they're still going to want to talk to you, but this way we can get all of the history stuff out of the way. Now, she loved this solution because it respected her dignity. I loved it because honestly, I was having a hard time remembering all the stuff as well. The physicians and the nurses loved it because it saved time. And I'm going to talk more about this again in the next slide. So always be brief and to the point when sharing information. As the little graphic says, you only have about 18 seconds before a doctor will interrupt you. Now, it's not because they're rude and impatient. Insurance companies, including Medicare, regulate how much time they can spend with a patient. So you have to plan in advance what you're going to say during your appointment. So cut to the chase. The physician doesn't need every little detail. For example, let's say you fell and injured your ankle. The doctor needs to know what happened before, during, and after. So keep it simple. Say something like, "This morning I was out for a walk and I must have tripped over the uneven pavement because before I knew it, I was on the ground. I had to call my daughter to come and get me. I still can't put any weight on my ankle and it's really hurting." And then the doctor can ask for whatever other details he or she may need. Now, that being said, always be sure to ask questions if explanations or instructions are unclear. Feel free to bring up issues that you think are important, and be sure that the doctor knows if you have concerns about a particular treatment or a new symptom that may have cropped up. Now, second opinions. My mom hated going for second opinions because she felt that it was disrespectful and she didn't want to hurt her doctor's feelings. She didn't want him to think that she didn't trust him. But hearing the views of two different doctors can help you decide what's best for you, especially when it's a serious diagnosis or when surgery is involved. In fact, many insurance plans, either require it, recommend it. By the way, that's the excuse that I always use with my mom. Your insurance says that we have to get a second opinion, Mom. Now, doctors are used to this practice, and most will not be insulted by your request for a second opinion. Your doctor may even be able to suggest other doctors who can review your case. Always remember to check with your insurance provider in advance just to find out if that second opinion is covered under your particular policy. Check to see if the new doctor is in your insurance network, if you have a Medicare Advantage plan or another HMO. And see if you need a referral from your primary doctor. And by the way, Medicare will almost always cover a second opinion. One of my favorite resources is a booklet from the National Institutes on Health called Tips for Talking with Your Doctor. Now, the title says doctor, but the booklet is really about communicating with all of the healthcare professionals that you may come in contact with. So I strongly recommend that you either download the PDF, or if you prefer, you can order a free booklet. So just go to the link on my resource list. Now, the booklet is directed more towards the patient, but it's invaluable for family caregivers, and it can really help to make our jobs easier. So I mentioned the brief medical history that I kept from my mom. It's essential that you always keep all of your loved ones' personal health records, and your own, up to date and accessible. The form that I used wasn't complicated. It was simply a Word doc that I typed up on my computer. Now, on the next slide, I'm going to share some fancier ways of managing information, but the most important thing is to use an organizational system that works for you. Now, just a couple of notes here. The identification section is self-explanatory, but just a note about the phone number. I never gave out my mom's phone number because I never wanted a healthcare professional to call her. Remember, she had dementia. So it was important that I received all important phone calls, emails, and written correspondence. So I listed my complete contact info. Now, I did list the name of the skilled nursing facility where she lived, so it would be clear that that's where she resided, but I gave no other details for her. And I tried to make it clear that all verbal and written information needed to be relayed to me. So make sure you keep that health insurance info current. Medicare is pretty static, but your supplemental plans tend to change. Also be sure that the healthcare providers know if your loved one is on Medi-Cal. I always took pictures of my mom's insurance cards and I kept them in my phone. Now, health contacts refers to not only physicians, but also therapists, preferred pharmacy, and specialists. Important legal documents include advance directives and powers of attorney. You need to have copies of these documents available to give to the hospital or new practitioners. But be sure to keep the originals in a safe place. And it's always good to have a couple of extra copies. Now, it's fine to keep these records and files on your computer, but be sure that they can be found by a family member should you be out of commission. One of the women in my support group recently had a very frustrating experience with just this. One of the most important things to have is an updated list of medications. So be sure to include the dosage and the reason for prescribing, because sometimes physicians can prescribe a medication for what's called off-label use, a use different from what it was originally approved for. Include the date it was prescribed and also list all meds that were discontinued. This will tell the physician that a particular medication has already been tried. Always list over-the-counter meds that are taken regularly, such as Tylenol, antacids, laxatives. Also list any vitamins or other supplements. Now, with medical marijuana being legal, many people are using THC or CBD for a variety of reasons. Be sure to list these. And of course, it's essential to list any drug or food allergies or sensitivities. Now, the medical history should include all hospitalizations that are relevant. You can probably skip a tonsillectomy at age 10, but any surgeries, ER visits, outpatient treatments, or medical procedures should be included. Also, make sure you list any implanted devices, such as a pacemaker or an intraocular device. Dates and the names of specialists are always helpful too. So the system I used with my mom many years ago wasn't computer-based, mostly because they really didn't exist, or most likely I wasn't aware of them. But today there's all kinds of online systems and apps that can be helpful, as long as you are comfortable using them. So I've listed a few, and not because I can endorse them, but just in case you want to check out some of them. Now, GoPatient, which is from Google, CareZone, and Caring Village, are all health-based apps. If you want to use Dropbox, that's kind of a generic system where you can store whatever documents you choose and share them with others. But my very favorite resource and personal health management system, and the one that I do feel comfortable endorsing, is one called Next Step in Care. So this site, it's from a nonprofit medical organization, is a one-stop center for everything a caregiver and a patient needs. They have more checklists and fillable forms than I ever could have imagined were necessary. They have videos and resources. Honestly, I use Next Step in Care all of the time when putting together my classes, including this one. So this is just an example of one of the fillable forms that's on the Next Step site. So this is their medication management form. Now, depending on the size of your screen, I don't know if you can read all the details, but I do encourage you to check out the site. So on this form, you can type in your own info into the blue boxes. You can save it and print it out, should you want to. It's a living document that can be updated and changed at any time. So it's so easy to use and share with your family members who are helping you with care. And one of the things I really like about Next Step is that you don't have to be a medical expert or a technical genius to use it. Now, most of us are familiar with the digital versions of our health records that are managed by our healthcare systems or providers. Kaiser, Sutter, Anthem Blue Cross, John Muir, they all have these electronic health records. So they can be convenient and relatively easy to use. However, I do have one caveat. All of your information is protected when it's on the practitioner or the facility site, and all of their software is HIPAA compliant. But once it's downloaded to your computer or your smartphone, It's up to you to be sure that your devices are protected with antivirus software. So read the terms of service and the privacy policy very carefully before storing your data. Also note that some non-HIPAA covered PHRs can market your data. So make sure that your system allows you the right to delete your record. Now, if you're using a wireless connection, be sure that it's encrypted, and you can look for a small lock symbol in the upper right-hand corner of the screen or in the URL. Sometimes it's listed on the far left part of the screen. However, the lock icon doesn't necessarily mean that the website's 100% safe, because hackers are getting more and more sophisticated, and they're using these little lock icons and the HTTPS notations. So never enter sensitive information like your social security number, your Medicare ID, or your credit card info unless you are sure of the link. And never click on a link from an email and enter sensitive information unless you have asked that that source contact you. And definitely never click on a link from a text message. The hackers are getting more and more devious. So I just recommend you keep a printed copy of your PHR in case the records get deleted or altered. And always double check that the information is accurate and up to date. All right, let's look at hospitalizations. We don't go to hospitals for a good time. There's always a crisis: stroke, heart attack, serious illness, falls, injuries, and everything is distressing, especially to an elderly person and one with dementia. There's a loss of privacy and there's invasive tests. And hospitalizations can confound existing impairments: vision and hearing issues, incontinence, problems with mobility, and again, dementia. And hospital care has changed a lot in the last 20 or 30 years. Patients are now admitted only for serious illnesses or injuries. They stay for shorter times, and many are discharged when their condition is stable, but before they're fully recovered. So discharges often happen with little advance notice, even though they are supposed to give you 24 hours. So as a family caregiver, you may have had this experience. Now, sadly, for those of us caring for an elderly loved one, a hospitalization, whether it be planned or an emergency, is not a matter of if, but when. And the best way I can help you to help yourself is to stress the importance of advanced preparation. Now, I've talked a lot today about having all of the important info and documents ready to go at a moment's notice. By the way, don't assume that the hospital or other medical facility has all of this information in their database. Even if they have some of it, they're still going to ask you a bajillion questions. And their info may not be up to date. So I got into the habit of double checking that they had the most current insurance info after a really bad experience with my mother-in-law. And always make sure that they have an accurate cell phone number so that they can contact you. Again, another bad experience, this time with my husband's hospitalization. So again, it's always good to check and double check and never assume anything. And I can't stress enough the importance of knowing your rights and responsibilities and where to go for help. So let's take a look at that. So you may not have known, but that as a family caregiver, you have rights. The California Hospital and Family Caregiver Law was enacted in 2017. It was originally called the CARE Act, and it's still called that in some other states. CARE stands for Caregiver Access, Record, and Enable. So when a patient's admitted to a hospital, either the admitting clerk or the nurse must offer the opportunity to record the name of a family caregiver in the patient's medical record. This is especially important when a patient is elderly or has dementia. The hospital must keep the caregiver informed of all discharge plans, and I'll talk more about this later. And the law stipulates that the hospital must provide education and instruction about any necessary aftercare tasks that the caregiver will perform at home, including medication management, injections, wound care, how to safely move the person from one space to another, etc. I really wish this was in place when I was caring for my mom. Now, because this is relatively new, you may encounter individuals or facilities who are not aware of it. So AARP has made these wallet cards available for every state, just in case you need a reminder, or some backup in case someone is questioning your rights as a family caregiver. And I do have a link to these cards on my resource list. So we've all heard about HIPAA, the federal law designed to protect our medical info from unauthorized use. It's also designed to help healthcare agencies share information with each other. It was actually supposed to expedite the process of sharing and protection, but most of us know that it seems to generate a lot of forms that we have to sign. And as a result, most of us don't even read all the forms that are shoved under our noses. And many people, even healthcare professionals, aren't totally up to speed on what you can and can't do under HIPAA. So overall, HIPAA is intended to balance a person's right to privacy with the need for health providers to communicate with others. So the goal of it was to provide proper care for patients and act in their best interest. Now, the privacy rule part of HIPAA gives you rights over your health information and sets rules and limits on who can look at it and who can receive that health information. The privacy rule applies to all forms of your protected health information, whether it be electronic, written, or verbal. Now, if you request it, your doctors must give you copies of your health information. This is known as the right of access. You also have the right to review and correct any erroneous information that's in your medical records. Now, this last big bullet point is really important for family caregivers. HIPAA does not prevent healthcare providers from sharing a patient's information with family if the patient does not object. And in some cases, physicians or other providers can use their professional judgment to determine that the patient does not object. And this can come into play when dealing with a person who has dementia. The information can also be shared with any family members who are involved in managing a loved one's health care or who are responsible for paying the bills. So if a provider tells you, the caregiver, that HIPAA prevents them from sharing your loved one's info with you, they may not be up to speed on what the privacy rule is all about. So this is where you can use your excellent diplomatic and assertive communication skills to help educate them. HIPAA is really complicated. So for more information, check out the HIPAA link on my resource list. It's designed for just ordinary people, so it's real easy to understand. The dreaded emergency room. I'd like to share some strategies that worked for me with my mom and my mother-in-law and my father-in-law. Unless the hospitalization has been scheduled, patients frequently are admitted to the hospital via the emergency room. And most of us know what emergency room waiting rooms are like. They tend to be loud, crowded, overstimulating, and sometimes frightening. Also, for the dementia patient, the unfamiliarity of the situation can cause further agitation and confusion. There's a lack of privacy. It's distressing to see others or hear others in pain. The wait always seems to be excessive. Now, hospitals have to triage the patients, and of course, the ones with the most serious conditions are going to be seen first. So here's a few strategies that worked for me. Now, I learned that when my mom went to the ER via transport, either an ambulance or medical transport that we hired, she didn't have to wait in the waiting room. Now, she didn't always get taken into a room, But even waiting on a gurney in the emergency department was better than being in the waiting room. By the way, if someone is transported to the hospital via ambulance and then admitted, the insurance usually picks up the bill. Now, medical transports are usually paid out of pocket. So these are the ones that you hire yourself. They can be pricey, and that all depends on the distance and if the person needs any type of care during the transport. But for me, it was worth it to not run the risk of driving my mom to the hospital myself if I didn't think calling 911 was in order. Or two, to be able to avoid that dreaded waiting room. Now, we had a better chance of being seen sooner if I made sure that all of her medical conditions were shared with the admitting clerk. So I always mentioned that she had a history of stroke and had had 2 heart attacks. I kind of wanted her to be bumped up on that triage list. I also always let them know that she had dementia and that everything needed to go through me. This is the time to be sure that your name and contact number are recorded on the chart. So I learned always to have a little headset, my mom's favorite music on my phone. You may want to have other distractions on hand as well, an iPad with family photos, some kind of a little game to play, whatever might work to keep your loved one calm and distracted. I always had to remind myself to breathe. My mom was an emotional sponge, and she would soak up my emotions and my disposition. And if I was stressed, she would be too. And I had to constantly remind myself that what I considered to be an emergency, such as my mom needing to use the restroom now, was not considered to be a real emergency. The staff is dealing with gunshots and strokes and now COVID. So it's not a biggie to them if my mom wet her pants. So just a few more tips. While there may be several family members who are concerned about the patient's well-being while hospitalized, for the sake of reducing confusion, it's best to designate just one family member as the point of contact. Now, unless the primary care physician was the one who suggested a hospitalization or an ER visit, they may not know that the patient has been hospitalized, and the hospital won't automatically contact them, even if you put their name in the record. So make sure that you call the primary care physician, just in case, just to let them know that your loved one has been hospitalized, give them the details, because you're going to find out that they can be a good ally for you. Now, many hospitals have doctors called hospitalists. These are the physicians who manage the care of hospitalized patients, but who do not have a private practice in the community. So ask the hospital nurse or social worker for help if you're not sure which doctor is the hospitalist assigned to your case. But it's been my experience that they usually come in and introduce themselves. But in case that doesn't happen, ask about that. Because hospitals can serve as a liaison between the hospital and the patient's primary care physician. They're the ones who really should update the primary care physician about why the patient was admitted, what tests were done, what results are still pending, and any medications that were changed. Now, I also discovered that hospitalists frequently have way more time to talk with you than some of the medical specialists do. The squeaky wheel. I always made sure that I introduced myself to the staff. I tried to be as much help to them as I could with regards to providing care for my mom. I always wanted them to know that I was part of her care team. Now, remember, it's your right to ask questions and to see all records and test results. Now, I tried to stay informed, but I also made every effort not to interfere with what the staff was doing. Now, even though my mom's dementia diagnosis was in her chart, I always tried to let the staff know about strategies that worked well with her. So she had vascular dementia, and she still had a lot of abilities left. Since her social abilities were still very much intact, Others didn't always understand that her short-term memory was impaired and that she had a hard time following directions. She couldn't remember where her call light was, nor could she remember what it was for. She had macular degeneration and was also hearing impaired. But you wouldn't know this just by looking at her because she did a great job of compensating. So it was really important that I was always there to advocate for her. And something I wish I had known years ago when I was my mom's caregiver, and that is where to go for help when you're in the hospital. Typically, there's a medical social worker that's assigned to each floor of the hospital. While these individuals are employed by the hospital, their job is to make sure that the patient's needs are being met. Sometimes they can serve as the discharge planner. And every hospital has a patient relations department, although the name of this department may vary. Patient relations liaisons work with hospital patients and their families to address any concerns or special needs they might have. They also work directly with administrators of the hospital to solve patient and family problems. They can also be called patient advocates. So if you have any concerns about the quality of care, ask how to get in touch with this department. And later on in the presentation, I'm going to be talking about other resources for advocacy. By the way, there's just a lot of information in this particular presentation. And I'm hoping that you have copies of my presentation slides, which are available on the website. If you can't find those or get to those, just send me an email and I'll make sure that you have them. One of the things that I have discovered, and I know that this is so true with my own learning, is that until I can personally relate to something that I'm learning, until I can make that personal connection, it doesn't really sink in. So a lot of this info is definitely good to have in advance. But when you get caught up in the middle of one of these situations, you're probably going to find that you've forgotten a lot of things. I know that's, again, so true for me. So at least you've got some resources to go back and review. Okay. So after a stint in the ER, the patient may be admitted. So there's two categories of hospital patients and patient care: inpatient and outpatient, also known as observation. With inpatient status, you are formally admitted with a doctor's order. A patient must meet certain criteria that are established by Medicare or your other insurance to be admitted as an inpatient. All inpatient costs, including care, tests, procedures, treatments, medications, are covered by Medicare Part A. Now, observation is supposed to be used temporarily while the doctor decides whether a person should be admitted to the hospital as an inpatient. The person will receive appropriate care and then discharged when the team feels that they are safe to leave the hospital. This care may be given in the ER, or the patient may be moved to a hospital room. Medicare Part B covers observation status because the patient is considered to be an outpatient. Now, most people assume that they're an inpatient at a hospital when they stay overnight. But increasingly, that may not be true. Recently, hospitals have been classifying more patients as outpatients or on observation, even if they're there for an overnight stay. So again, you might be an outpatient even if you stayed overnight in a regular hospital bed. By the way, this happened to me last September, and I'll tell you more about that later. Now, it's supposed to be temporary, but sometimes hospitalized patients stay in observation status for many days. I was there for 3. So why is this? Observation status is used by hospitals to avoid losing money, to avoid accruing financial penalties, and being accused of Medicare fraud. Because hospitals get penalized by Medicare if they admit a patient, discharge him in a few days, possibly prematurely, only to have him be readmitted less than 30 days later. So to get around the Medicare penalty, hospitals began using this outpatient status. However, this status seriously affects Medicare beneficiaries' access to care and coverage. So what are these issues? How can observation status adversely affect the patient? So there's higher out-of-pocket costs because Medicare Part B is responsible for outpatient services, and it pays differently than Part A. You're going to have higher copays and deductibles. Remember, observation is considered to be outpatient. The other huge issue with observation status is if the patient needs skilled nursing care after discharge. In that case, Medicare will only cover the first 100 days if the patient has inpatient status for at least a 3-night stay. And this is referred to as 3 midnights. Skilled nursing home care is only paid by Medicare if the patient requires medically necessary treatment. That is, not just custodial care, such as assistance with eating, dressing, bathing, walking, etc. And only if they're discharged to a skilled nursing facility after a 3-night inpatient hospital stay. Now, some Medicare Advantage plans like Kaiser's and Medi-Cal have different guidelines. They're usually more lenient, so that's a good thing. Medi-Cal, I believe, just requires 2 midnights. So ask the staff to confirm admission status and make a written note of this. And make a note of who gave you that information, because you may need to follow up on that later. Now, you can't formally appeal admission status, but you can request that it be changed. Your best chance is to ask the patient's primary care physician to talk to the hospital physician and ask them to intervene on the patient's behalf. They know the medical history and they speak the same medical jargon as the hospital physician. The patient's own doctor might be able to convince the hospital physician that the hospital status should be changed from observation to inpatient, especially if the writing on the wall indicates that the patient will ultimately need skilled nursing care upon discharge. So the hospital can retroactively change the patient's status from outpatient to inpatient, but this change needs to be made while the patient is still in the hospital with written notification. So again, if it looks like skilled nursing care is in the picture, a status change is going to be worth fighting for. Now, another big expense with observation status is who pays for medications. When the patient is in for observation, not all medications are covered. Only IV drugs and the ones that are associated with the reason for admittance and that are prescribed during the hospital stay. So, self-administered medications are any medications that the patient has been previously prescribed. So this also includes over-the-counter meds. And if any of these meds are not related to the hospital stay, they will not be covered by Medicare Part B. So let me give you an example. Let's say a person is hospitalized for intense intestinal pain. Now, if that person regularly takes a medication for high blood pressure, and let's say another one, say Symbicort for COPD, now neither of those meds will be paid for because they're not related to the intestinal issue. And you're not supposed to bring your own prescriptions. So the hospital pharmacy will supply your what are called maintenance meds, the meds you take on a regular basis. And you will have to pay out of pocket for them, usually at prices that are way higher than you normally pay. So if, for example, you take Tylenol for your arthritis pain, but you're not in the hospital for arthritis, the hospital can charge you an exorbitant amount for the Tylenol. So these hospital supplies medications that fall into the self-administered category can often run into the thousands for just a day or two stay if the patient has lots of meds. Because not only are you charged for the actual medication, but you're charged because the nursing staff needs to give them to you, which makes the name of these meds, self-administered meds, not make a whole lot of sense. Anyway, now, if you have a Medicare prescription drug plan known as Medicare Part D, that plan may cover your self-administered meds. And so here's how that usually works. The patient is going to have to pay up front when they get their hospital bill. And then they submit a request for reimbursement to the Medicare prescription drug plan and hope they pay. By the way, when I was in this situation, my Part D plan wouldn't pay. Now, some Medicare Advantage plans have different coverage, so be sure to check. And the best person to ask is your nurse case manager or the hospital social worker. Now, good news for the patient with Medi-Cal as their insurance, because they can't be billed for any copays or deductibles or self-administered meds. So can you bring your own prescriptions and over-the-counter meds such as Tylenol? You're not really supposed to. The protocols vary from hospital to hospital, so it's always important to ask. You can ask the hospital's pharmacy to verify your meds. They may or may not do so. And remember, if the nursing staff administers your meds, in other words, hands them to you, you're going to be charged for that service. So another example, I recently experienced this firsthand. I thought I was going in for a 1-hour outpatient surgery to repair a fractured kneecap. But due to adverse effects from mismanaged anesthesia, I was admitted for what turned out to be a 3-day stay. Now, since I had been given way too many pain pills as a result of the anesthesia mishap, I was delirious. I had no idea what was happening. So I was unable to ask questions or advocate for myself. And of course, because I don't always follow my own advice, I foolishly had never taught my husband what to do in situations like this. So we were at the mercy of the hospital. Now, since I was assigned to a regular hospital room, neither my husband nor I realized that I'd been admitted under observation, in other words, as an outpatient. Now, because I take 3 different maintenance meds that were not related to my fracture repair, I was charged for those meds. By the way, with my prescription drug plan, these meds are so cheap that I have no copay for them. So I was given a total of 5 pills over the course of 3 days and was charged $990 by the hospital. This was not okay. The reason that I spent 2 nights and 3 miserable days in the hospital was because the medical staff screwed up. And now they were charging me nearly $1,000 for their mistake. So I got my orthopedic surgeon involved. He contacted the hospital on my behalf, and the charge was waived. Honestly, I think everybody was afraid of litigation. But the point is, never hesitate to challenge things when you think that something is not right. Okay, I've spent a lot of time on this topic because it's a really important one. Observation status can have a lot of ramifications, and it's blindsided so many people with serious financial implications. So because of this, Medicare adopted a new policy in 2017. So now a hospital must formally notify patients who are admitted under observation. They must provide written and verbal notice within 36 hours of the hospital stay to all patients who are admitted under observation. This is known as the Medicare Outpatient Observation Notice, or the MOON form. The document specifies how observation status can impact hospital coverage and how it can impact Medicare's payment of aftercare services, such as skilled nursing or home health. So be careful. The hospital may relay this information to the patient, but not to the family caregiver, even though the CARE Act says that they must. and the form may get lost in the massive pile of paperwork that gets shoved under our noses. Or, as in my case, the hospital never gave us one of those forms. And 36 hours may be too late. You will already have missed one of those 3 midnights that are necessary if you're discharged for post-acute care to skilled nursing. So as a care partner and as a patient yourself, if able, you have to be vigilant in asking about this. So here's what that form looks like. Now, I don't expect you to be able to read the screen, but you can download a copy of this form if you're interested, and I have a link to that on my resource list. So what I have up here is Medicare's template. So each facility will add their own information, their logo, name, address, etc. The form states that the patient is admitted under observation and the reason why. It then states how this status will impact the patient financially, including increased costs for medications. It also states that Medicare's ability to pay for skilled nursing care is impacted. They ask the patient or the family caregiver to sign the form, but they don't tell you what you can do because technically you can't appeal this. But as I mentioned previously, you can try to get your primary care physician involved to work with either the hospitalist or the hospital to change your status from outpatient to inpatient. So during the admission process, and then again prior to discharge, the hospital is supposed to provide all Medicare recipients with a 2-page form called An Important Message from Medicare, because this form explains your rights, including the right to receive all necessary hospital care as covered by Medicare or your Medicare health plan. You must be informed of all decisions relating to your hospital stay and your Medicare health plan, and importantly, what services and procedures will be covered. Sometime prior to discharge, the case manager should let you know what your insurance will cover, including medications and copays. Now, the form also outlines your right to appeal a discharge and gives you instructions about how to file the appeal. And lastly, the hospital must arrange for all necessary services such as home health care, special medical equipment when you leave the hospital. And they also need to let you know who's going to be paying for those and how to get them. More about that in a minute. So here's what the important message from Medicare form looks like. Again, every hospital is going to put their own logo and contact info at the top of the notice. Your rights are listed next, including your right to express concerns about the quality of your care to an independent reviewer. Now, in California, the organization is called Levanta, and their phone number will be on the form. And by the way, I have the link, the direct link to Levanta on your resource list. So Levanta is responsible for medical case review. So these rights include making sure that you get the healthcare services that the law says you're entitled to. They can help you if you have a concern about the care you've been receiving, or if you want to request a review, also known as an appeal, of your discharge from a healthcare facility. The form includes your rights in appealing a discharge and the process for doing so. And we're going to look at this in more detail in another slide. Okay, the last step in a hospital stay is the discharge process. Medicare states that discharge planning is a process used to decide what a patient needs for a smooth move from one level of care to another. Now, only a doctor can authorize a patient's release from the hospital, but the actual process of discharge planning can be completed by a social worker, a nurse, or the case manager. Now, the generic term to remember here is discharge planner. So for the sake of simplicity today, I'm going to use that term. Now, ideally, and especially for the most complicated medical conditions, discharge planning is done with a team approach. So patients are evaluated by their physicians and their specialists and any therapists who've been involved in care. The information is discussed with the patient and the family caregiver. The discharge planner will work with the patient and the family to determine if the patient can go home or if he or she needs to go to a care facility. And the staff must explain to you their recommendations for what's called after discharge care. So as a family caregiver, be sure to communicate clearly to the planner what your capabilities are, what your limitations are, and what your wishes are. Because if you are unable to provide care at home, be sure to state that. Now, at a minimum, this discharge planning must be done and discussed with the family at least 24 hours before the day of discharge. Remember, it's your right to ask when a discharge is expected because you need time to plan on your end. With my mom, which was again prior to all of these nice little Medicare forms, I just got in the habit of asking every day what was going on. I think they kind of got tired of me, but that's okay. Most people discharged from a hospital stay will need some type of care afterwards. Now, decision-making about post-acute care can be challenging for everyone, but this can even be more daunting for the elderly or those with complex medical needs or cognitive impairment. Families often struggle to determine what care agencies or facilities are best for them. And sometimes it's not easy to find the right placement. These days, due to lack of availability, it's really frustrating. And then adding to that uncertainty are insurance constraints. You may have to find a facility or an agency that's within your provider's network. And this can be the case for those who have a Medicare Advantage plan. And something else I learned recently, sometimes a provider network is specific to the county in which the patient lived when they obtained their insurance plan. So let me give you a little bit more information about this and an example. A caregiver recently shared with me a problem that her family encountered with this provider network. Their elderly mother resided in one county when she signed up for her insurance plan. But due to some medical conditions and issues, she was no longer able to live in her home. So she moved in with her daughter, another daughter who lived in another county. A couple of years later, the mom was hospitalized due to a fall, and she needed to be discharged to a post-acute care facility, skilled nursing. But instead of being able to be in a facility that was close to her family so that they could provide support for her, her Medicare Advantage plan would only cover her if she went to a facility in the county in which she purchased the insurance. So that's important to note. I mean, this may not be an issue, for a lot of people, but it could certainly be an issue for some. So also, just be aware that some insurance plans have benefit limits, such as how many days are covered. Now, while discharge planners make every effort in developing safe and appropriate discharge plans, the ultimate decision is placed on patients and families. And again, within the restrictions of the insurance provider. So this time-sensitive process must often be completed within 24 to 48 hours, which can overwhelm sick patients and their families, especially during a medical crisis. Now, you do have the right to appeal a discharge if you feel that it's unsafe, and we'll talk more about that in a minute. So there are a variety of permutations regarding aftercare options, but I'm just going to talk about the most common ones here. Patients who don't need round-the-clock skilled nursing care may be discharged home, either their own home or sometimes the family's home. Now, if they're able to go home, they may require support from a certified home health agency. And the physician will usually be the one to order home health care, depending on the needs of the patient. But this is not 24/7 care. This care is designed to be intermittent, maybe 2 or 3 times a week. And the patient needs to be homebound, meaning that it's not possible for them to be transported to a clinic or the physical therapist's office or a rehab center. Now, Medicare pays for all skilled services from healthcare professionals. So you shouldn't be out of pocket for any of this. Now, of course, with discharge, we want to look at what the caregiver is able to do, the supplies that are needed, and whether the home environment is a safe one. So oftentimes a nurse from the home health agency is going to make a preliminary visit to check on home safety and make recommendations for modifications such as installing stability bars in the bathroom, removing throw rugs, getting rid of clutter that may prove to be a fall risk, making sure that the lighting is adequate. They also want to be sure that the caregiver has the help needed, either from family or friends, or that they may need to hire what's called a personal care agency. Personal care is not covered by insurance. Okay, only home health care is covered, and health is the operative word. Now, if as the family caregiver, you don't feel you're able to provide care at home, you may want to ask the doctor if an order for a skilled nursing facility is possible. Those who are recovering from a stroke, a surgery, or a serious injury may need intensive therapies that can be provided at an acute rehab hospital. Now, all of these services are covered by medical insurance. The patient will stay at the rehab hospital until it's safe for them to go home. And by the way, sometimes these rehab hospitals are also called skilled nursing facilities, and I know that can be confusing for a lot of us. It would be nice if all the names were consistent, but that's not the case. And lastly, discharge to a skilled nursing facility is a fairly common option for the elderly who need some type of round-the-clock medically necessary care. Hospital staff must provide lists of options for care, but it's the patient and or family, it's their responsibility to choose the specific agency and the specific facility. Now, this is done to avoid any conflicts of interest in case the hospital has any financial ties to agencies or facilities. Now, I talked more about skilled nursing facilities in I believe it was the January webinar. The recording and resources are posted on our website. So if you missed that particular one and want more info about skilled nursing facilities, that's going to be the best place to go. Now, most patients and families wouldn't mind having some help because most of us aren't familiar with what's available in our areas or which facilities are safe and good. But since federal law and regulations guarantee that you have your choice of where to go, again, within that network, and which agencies to use, hospitals are restricted in the amount of guidance that they can actually provide. Okay, so sometimes prior to discharge, the discharge planner should let you know what follow-up care your insurance will cover, including medications and copays. The discharge planner has access to all of your insurance information. This may be a good time to make sure, again, that the hospital has your accurate and up-to-date insurance policies. Be sure they run your insurance. This means that they've checked that your policy is online and they've checked that everything is current. Sometimes in the craziness of getting admitted, especially in an emergency situation, that can slip through the cracks. That actually happened with my mother-in-law once, and that was not a good thing. A list of medications is one of the most important components of the discharge order. If there's new meds, the discharge planner will either fax orders to your pharmacy or will give you the prescription. The discharge planner must go over the entire meds list with you and provide instructions. Now remember, the discharge planner knows what kind of insurance you have. And if a particular medication is either not covered by your insurance or has a high copay, be sure to ask the discharge planner if there's any coupons that might apply. So here's an example for you. When my husband had open heart surgery a couple of years ago, he was discharged with a new prescription for a drug called Eliquis. Now, since prior to his surgery, he had never even used his prescription drug plan, he had not met the deductible. So our copay for the Eliquis was going to be $400 for 1 month. I asked the discharge planner if she had any coupons from the manufacturer of Eliquis, and she said she did, but because our insurance was so good, we didn't qualify for the coupon. I didn't quite understand that logic. So I asked her if I could have the coupon anyway. Now, I showed the coupon to our pharmacist, and as it turned out, the coupon was for a 1 month free trial for Eliquis, and it didn't matter what our insurance was. So we got that 1 month free. Now, my husband had to be on that med for 6 weeks. So we then asked his cardiologist if he had any samples, because drug companies always give physicians samples. Yep, he did. So we got another 2 weeks free. The moral of the story: always ask if there's anything that can be done to help you cut costs. Now, if the patient's going to be going home, the hospital staff must train the family caregiver to perform any necessary tasks. Remember that CARE Act we talked about earlier. So the training can be done orally, in written form, or by video. It all depends on how complicated the training is. So your loved one cannot be discharged home until the hospital is certain that the family caregiver is able to provide adequate care. The discharge planner will let you know if the doctor has ordered that the patient needs to be seen by a home health agency. And we talked about this a minute ago, and they're going to give you a list of agencies from which to choose. Now, the discharge planner should send the doctor's order to the agency that you select, and then that agency will contact you to set up appointments. And this is all usually done in a very timely manner, because frequently the home health visits are going to start within a day or so of you being discharged home. And remember, this is home health care, and it's got the word health in it. That means your insurance is going to cover the costs. Now, if the patient needs any special medical equipment, so devices such as walkers, wheelchairs, crutches, maybe even a hospital bed or a bedside commode, the discharge planner will let you know where you can get that and if your insurance will pay. They usually do. So there's companies that will drop off the equipment and then pick it up when it's no longer needed. Now, regarding follow-up appointments or tests, it's very important that patients be seen by their own physicians within 7 days of discharge. So the discharge planner should contact the physician to provide information about the hospital stay. Then the family follows up to make that appointment. Now, again, the discharge planner should make the initial call, but it's your responsibility to actually make the appointment. So don't delay in doing so. So it's also your responsibility to ensure that any physician or specialist that you see or the patient sees after a hospital stay accepts their insurance. So you can't assume that just because your discharge plan says, see Dr. X, that Dr. X takes your insurance. Now, Dr. X's services may be covered by your insurance while you're in the hospital, but your insurance may not cover Dr. X if you're seeing him or her as an outpatient. Then you're going to be stuck with the bill. This happened to my husband and I. We appealed it, saying that, wait a minute, Dr. X was listed in the discharge orders, so how were we to know any differently? But we were told that it's the patient's responsibility to confirm that the doctor is in the network. We even filed an appeal, but it was denied. So if you have a Medicare supplement plan, you don't have to worry about this, but Medicare Advantage plans tend to work like HMOs. So there can be a lot of out-of-network costs. So I did go over the discharge process in the previous slide, but Medicare has established that the patient's family caregiver has certain rights. These are really important, so I just want to review. Remember, you need to be told the expected expected date of discharge at least 24 hours prior. The staff must explain their recommendations for after discharge care to you, not just hand you a stack of papers and say, here, read this. Because if there's anything you don't understand, you need to ask. You have the right to be involved in choosing where your family will go after discharge. Remember, medical necessity may dictate if it's going home or going to a facility, but you have the right to choose which facility, again, as long as it's in your network. Very frustrating. So you can't be forced by the hospital to go to a facility that's not in a good location for you, or a facility that you don't like. So if the patient's on Medicare, the facility must be Medicare approved. If the patient is on Medi-Cal, it must be Medi-Cal approved. And if the patient has an HMO or Medicare Advantage plan, it must be in network. The patient can't be forced to leave the hospital until an appropriate placement is located, because that would be considered an unsafe discharge. So depending on what the medical team's recommendation is, the discharge planner must give you a list of possible facilities, home health agencies, and/or personal home care agencies. Again, they can't make any recommendations or referrals, and it's up to you to do the research, up to you to research the options and make the phone call to arrange for services. So I have a link to Medicare's Care Compare tool on my resource list. It's an excellent and really easy resource to use. And lastly, you have the right to appeal the discharge. So more to come on that. Okay, everything I just said about discharge, the discharge process may sound like blah, blah, blah to you right now, because remember, sometimes it's hard for us to process and digest information that we don't need immediately. I know it is for me. So I have several sites for information about discharge planning on my resource list for when you need this info in the future. Now, my two absolute favorites are Next Step in Care. I spent some time talking about that one a few slides back. And Medicare's Discharge Planning Checklist. So I have the link to that booklet on my resource list, and it's excellent. This slide shows the first couple of pages of the 6-page booklet, and I just wanted to give you a real quick sense of what it looked like. So sometimes the hospital creates a discharge plan that you don't want, that you don't agree with, or that you don't feel is safe for your situation. So you have the right to appeal the decision. However, before you formally appeal the process, it's always good to talk with the doctor, the hospital's medical social worker, or the discharge planner. Express your concerns, and hopefully they can adjust the discharge timeline to better meet your needs. Now, by law, the hospital must let you know how to appeal and explain what will happen. And this is true for patients under the age of 65 and also for Medicare patients. So now I'm going to assume that most of you are caring for a loved one on Medicare, or you yourself are on Medicare. So I'm going to talk about Medicare's process. So do you remember that important message from Medicare form that I showed you a few slides back? You may remember that a big chunk of it describes the appeals process. So should you choose to file an appeal while awaiting the decision, should you choose to file an appeal while you're awaiting that decision, you can stay in the hospital without paying. Now, of course, coinsurance and deductions are going to apply. So the magic words to use when you're appealing a discharge: you need to say that you feel that this discharge is unsafe and explain why. And unsafe could be as simple as, you're discharging him home and I don't have the capabilities to take care of his care at home. We need to figure out something else here. Okay, here's that form again. So remember, it lists your rights and it gives you the steps for appealing a discharge and what the timeline is. Don't miss the deadline. And the most important phone number is the Levanta number. You can start the appeal process simply by calling that phone number. Okay, so now your loved one has been discharged and is receiving home health care, or is in outpatient rehab or skilled nursing. Medicare is going to pay for all of that, but they have guidelines for when they will pay and when they will stop. Medicare must inform you in writing if they will no longer cover any of those services after a certain date. They'll send a form called Notice of Medicare Non-Coverage. Now, you have the right to appeal their decision to stop coverage, and the form gives you all of the details, including what you need to do to get an immediate appeal. Timeline is tight, and you must make the phone call to Levanta, again, if you're in California, before noon on the day that the services will no longer be covered. Now, if your appeal is denied, the services will not be covered either by Medicare or your Medicare Advantage or Supplement plan. So this form is different from the important message from Medicare that details your rights to appeal. And here's what this form looks like. So all of your rights and responsibilities are listed on this form. It will include the phone number for Quality Improvement Organization, Levanta again, and all of the details you need. Now, if you miss the deadline for filing an immediate appeal, it even gives you another option. Again, this form tells you that Medicare will no longer pay for home health, rehab, or skilled nursing, and why, and how you can appeal the decision. So you can find a link to this form on my resource list. Okay, I know we're a little past 11:30 now. I probably have about 5 more minutes. Okay, so let's say that Medicare has sent out their notice of non-coverage, but you disagree with their decision. You feel that your mom still needs physical therapy. So in the past, if a patient either at home, in a skilled nursing facility, or in an outpatient clinic did not appear to make any progress with the treatment they were given, then Medicare would stop paying for that treatment. This was not good because most people would decline, their health would decline after the treatment was stopped. And in many cases, they'd end up needing even more care. So in 2013, a class action lawsuit was filed against the federal government, and the plaintiffs won. So what's known as the JIMO settlement agreement was approved in 2014. So remember, it used to be that if a patient was no longer making any progress, in other words, they'd reached a plateau, Medicare would not continue to pay for their physical therapy, their occupational therapy, whatever it was that they needed. But the JIMO settlement changed all of that. So now if a patient needs skilled home health care or outpatient therapy services such as physical and occupational therapy, in order to maintain their current condition or prevent decline or deterioration, coverage cannot be denied based on the absence of potential for improvement or restoration. Okay, super important. So the JIMO settlement stated that Medicare skilled health coverage is not just a short-term acute care benefit. Under the law, Medicare beneficiaries who meet the qualifying criteria are eligible for skilled health services as long as this type of care is reasonable and necessary. Months, years. Now, a big chunk of healthcare professionals are still not aware of the JIMO settlement. I have a link on my resource page that you can use to help you appeal if services are being discontinued due to lack of progress. Okay, really important info on this slide. Okay, So let's just take a look at some organizations and individuals who can help you to be an effective advocate for your loved one. So the first one, beneficiary and family-centered care. Family-centered care quality improvement organizations provide medical case review. And these are the organizations that you call if you want to appeal a Medicare decision. But you can also call them if you feel that you're not getting proper care. So these organizations may vary from state to state, but in California, remember, the organization's name is Levanta. You can start the appeals or complaint process simply by calling the 877 phone number. And Levanta's number must be listed on any Medicare form in California that the hospital gives you. And I'm going to talk more about these quality improvement organizations in just a couple minutes. So California Advocates for Nursing Home Reform, or CANR, is probably my favorite advocacy organization. Now, the information they provide is not just for those in nursing homes, but for pretty much every aspect of elder care and rights. Their website is full of excellent and up-to-date information about everything from Medi-Cal, getting approved for Medi-Cal, to all types of care facilities. They have legal experts on staff to answer your questions. So I've used this service several times, either with a phone call or by leaving an email request. They always respond within 24 hours, and they always follow up to make sure that my issue had been resolved. So if you've attended any of my presentations or webinars, you know that I always use CANR as a resource. Now, the Center for Medicare Advocacy provides comprehensive legal analysis, education, and support for individuals and families. The Medicare Rights Center is a national consumer service organization that works to ensure that affordable health care for older adults and people with disabilities is available. So I use all three of these nonprofit organizations in doing research for this particular webinar. Now, the long-term care ombudsman are advocates for residents of nursing homes, board and care homes, and assisted living facilities. Ombudsmen can provide information about how to find a facility and what to do to get quality care. And these individuals are trained to resolve problems, and they can assist you with complaints. So you can find your local ombudsman by entering your zip code on the website that I have listed here. It's also listed on my resource list. Long-term care ombudsmen don't help with hospital issues, but they focus on issues with long-term care facilities. So every nursing home, assisted living facility, and board and care should have the local ombudsman contact information posted. It's frequently posted right next to the form that shows what their Medicare rating is. And then, as I mentioned earlier, every hospital should have a patient relations department or hospital privacy officer. These are individuals or teams that objectively handle patient issues and complaints, as well as conduct internal reviews. So if you have a complaint, ask about how you can contact the patient relations department. And then I've mentioned these individuals before, but another excellent resource for patients is the medical social worker. So when my mom was admitted to the hospital, I would always ask for the name of the social worker on the floor that she was on. Because medical social workers, they've received special training to work in medical facilities. And they can also act as the discharge planner. But again, varies a lot from hospital to hospital. I can't tell you how many times the hospital social worker has come to my rescue, not only for my mom, but for my mother-in-law and my father-in-law. Okay, so how do you file a complaint? First of all, it is always best to contact the facility and to let them know what the issues are before you file a formal complaint. Let them know that you have a formal complaint and that you intend to file it, because this generally gets their attention and hopefully motivates them to make things right. Now, in most cases, you can file a complaint anonymously, but it's actually better if you provide your name and contact information. They'll take you a bit more seriously, and then that way you can be contacted should further information be needed. And always be sure to keep as much documentation about your concerns as possible. So this can include email and text messages, voicemail messages, actual paperwork that you've received, and even notes that you've taken about the situation. So here are 3 agencies that may be able to handle your complaints. All 3 of these have convenient online reporting forms as well as phone numbers where you can talk to actual people. And all of this information that I have listed here is also on my resource list. So the Community Care Licensing online complaint form is provided by the California Department of Social Services. Now, this form is primarily for complaints about facilities that serve older adults and children. So for complaints regarding Medicare or Medi-Cal fraud, you can file an online complaint with the U.S. Department of Health and Human Services. And this is in their Office of the Inspector General. This reporting system covers healthcare fraud, quality of care issues, and medical identity theft, among several others. So you can either complete the online form or call the number that's listed here. Now, I mentioned Canner in the previous slide. They also have an online form for asking questions and filing complaints. Don't hesitate to voice your concerns because you'll not only be helping yourself, but you're going to be helping others in the community who may have had similar unsatisfactory experiences. Okay, so I know I bombarded you with lots and lots of information, but as always, you have a resource list, the slides are available, and the recording is posted online should you ever need this information. So I hope you're always going to remember that you are a really important member of the healthcare team. So do your best to be prepared, to be organized, and assertive. Always do your research or take advantage of mine and be an informed consumer of healthcare services. Know your rights, stand up for them, and advocate for your loved one.